and I think is becoming more commonly used in everyday practice for oncologists. It requires obviously different tools, and that's why it's different, the challenge for application in various continents and countries. First, the access to molecular tests. They allowed us to understand better the disease, the drivers, the mutations, and then access to the drugs. They will obviously be used against these mutations. The health system had to deal with this reality of supporting the testing of a large population of patients for different economic reality. The tests can be very simple or much more complex and expanded. But what's the other side of the coin? We can save more lives. Of course, we can prevent the recurrence of many diseases in a high-risk setting. We can reduce the mortality from these patients. So I think the implementation of these different molecular tests in early disease or in advanced disease has the advantage to improve care, to control symptoms. From patient point of view, we always talk about symptoms and quality of life. And of course, in the early setting, to reduce the chance of recurrence or delay recurrence, overall improving survival. One of the major barriers to the implementation of precision medicine remains the cost. The cost of molecular testing, particularly for liquid biopsy, the cost of repeated molecular testing. If I can use more molecular tests, liquid biopsy reduce, for example, imaging, reduce the length of treatment, reduce the cost of drugs. And if we can do that, probably the cost of the NGS liquid biopsy and implementation of precision medicine will be affordable. There is a pressure from different reality, from the patient, from the physician, from the health organizations to really push for the implementation of precision medicine. Nobody wants to have iPhone version 1. You want to have iPhone version 17 because we know it has different capabilities. We are not going back, that's for sure.